Welcome, everyone. We'll get started in just another minute or two. I see a few more joining us. If you want to go ahead and just drop your name and organization in the chat. We'll get the chat enabled here. Give me just a second. See some names and organizations coming in. Thank you, Shannon. If you all want to just drop those in the chat, we'll get started in just one more minute. All right, well, we'll go ahead and get started. Welcome. Thank you guys for joining us today. My name is Lauren Gonzalez. I'm the communications manager for the VNPC. A few quick announcements. If you haven't seen it, we just launched our new website. So govnpc.org is the new URL. So definitely check it out if you haven't had a chance. Another reminder to mark your calendar. The October Summit is going to be here before you know it. That's October 22nd to the 23rd at the Great Wolf Lodge in Williamsburg, Virginia. And we'll have more details about the agenda coming soon, but the lodging information is already on the new website. Just a reminder, many of you know that this recording will be on our YouTube channel within 48 hours. So keep an eye out for that. Tell your coworkers if they didn't get a chance to make it live. And with that, we'll go ahead and dive in. So our title today for our June webinar is 2SLGBTQIA+ communities and the perinatal experience. And I am so excited to give a warm welcome to Featherstone. They are a dual certified nurse practitioner of women's health and psychiatry. They are passionate about the mental health of parents and LGBTQ+ folks, healthy sexuality, and health literacy. After serving in the United States Army, Featherstone went on to pursue nursing and provide the compassionate healthcare that everyone deserves, but some struggle to find. They founded Eucalyptus Health in 2020 to offer psychiatric and sexual health care via telehealth to teens, parents, and queer adults in Idaho and Virginia. So join me in giving a warm welcome to Featherstone.
Thank you so much for the glowing introduction, Lauren. I am located in Richmond, Virginia, and I'm really excited to see how we have people from all over the state who are tuning in. I love that VNPC has such a wide net of folks that it supports. I have a sort of framing of today's presentation that I want to share. I recently was contracted by Postpartum Support International, which is the perinatal mental health certification sort of administrator as far as professional organizations go, to rework their LGBTQ focused content in conjunction with Laura Vladmirova, who is a perinatal therapist up in New York City. And so I just used those slides for today. Some of them are a little more in depth than what I think you all will need. So I will sort of skim the ones that are less salient. But I'm really excited to share this content. Just pulling up, here we go. Okay, so I really want to contextualize where we're working from, is to improve the respect that we give patients, the quality of care we give, and the mental health equity especially for people having babies who are in the queer community. I always like to say that the queer community is not a monolith. And so part of your job as a provider or shaping the culture of an organization is really to encourage an attitude of curiosity, but also being aware that there is such a thing as toxic curiosity, and we shouldn't ask questions unless they are really related to building rapport or changing healthcare decisions for our patients. We were asked to update this presentation in particular because a lot of the slides from 3 or 4 years ago were just basically saying like, there's no data. There's no data. We don't know. And the good news is that there is more data, but a lot of this is information that was already available in the queer community. It just wasn't documented by the scientific community. Lesbian parents have been asking family for sperm, asking friends in the community, building families for a long time, just like trans men and genderqueer folks have been having babies. It just hasn't been documented well. And so we want to have the caveat that this is not a new phenomenon. It's just new that we're documenting it and really studying it. The reason why a lot of the language in the perinatal space has shifted to birthing people is because not everyone who gives birth identifies as a mom or wants to be called mama. Inclusiveness, though, doesn't mean that we don't ever use that word. We just need to be aware of what the preferences of the people that we're working with. We also can't assume that every couple is a heterosexual couple, meaning that both parents are heterosexual. There's lots of people who are bisexual who are sort of invisible because they're in heterosexual relationships. We also can't assume that a parent has a partner. So there's plenty of people who are just in situations, whether by choice or circumstances, they're having a baby alone. I've had genderqueer patients in particular who felt a lot of gender dysphoria going into the labor and delivery environment and having everyone call them mama or mom and ask about where dad was. Because there's a lot of assumptions about people preferring that gender language around their new role as a parent. So asking people about what they want to be called and things like that is really like basic, but also these are some examples of the more broad language that are really being encouraged now. So birthing person or gestational parent, as opposed to the partner who is the non-gestational parent or the birth partner. And also as far as lactation goes, infant body feeding or chest feeding, because some people are sensitive to their body being called breasts. That's a very gendered term. A lot of publications in the perinatal space use exclusively cis woman-centric language. Cis meaning people identify with the gender they were assigned at birth. So someone who's born with a uterus who identifies as a woman. And the majority of people are cisgender, but a lot of the queer community just shortens it to cis or trans as opposed to cisgender or transgender. A lot of the health research on pregnancy inadvertently reinforces cisnormative and binary models of gender, in turn increasing and perpetuating erasure of gender diverse folks. And they found in one particular study from the UK that improving the language can help to reduce discrimination of parents who are having babies and who are trans and gender nonconforming. There was one really problematic finding that they found in this study of midwives in Canada, where there were midwives who were like, I don't need to ask about gender. It doesn't matter because I provide the same care to everybody. But the fact of the matter is, there are unique mental health needs and sometimes physical health needs to the queer community. And if we don't ask, we can't tailor our care. And so it's not the standard of care that those folks deserve. And if you want to go back and watch it at another time, I will share these slides, or at least this link, to this really amazing video where they talk about, it's all people from the queer community talking about how if they don't feel like their identity is understood, they don't feel like they have the appropriate rapport that they need to be cared for. And I think that's really an important thing for us to know when working with this community. In 2019, there was a survey, and of all the queer people they surveyed, about a third of them were raising children. Whether or not they'd given birth to them or not, they were involved in raising children in a parent role. So that included same-sex couples, same-gender couples. And the thing that was really interesting was that same-gender couples were 6 times more likely to be raising foster children or adopted children. Assisted reproductive technology is often a big part of the experience of becoming a parent, because same-sex couples will struggle with conception without intervention. That's why adoption and co-parenting and foster care are often easier and less cost prohibitive than options like insemination or in vitro fertilization. Some couples where one partner is trans in a heterosexual couple or polyfamilies may not need those interventions, but there's also options like reciprocal IVF, where an embryo from partner A is inseminated and implanted into partner B. So both parents have a biological connection to the baby, even if genetically the baby is not related to the gestational carrier. But highlighting all that to say that queer people or families wanting to be parents, it can be a medically complex, expensive, and sort of decision fatigue involving process, because it's stressors from all directions. And so keeping in mind that people who have to go through those processes have these additional challenges, and that they've worked really hard to be parents, compared to, you know, half of heterosexual cisgender couples who have poorly timed or undesired pregnancies. When we're looking at perinatal mental health outcomes in the queer community, a lot of lesbian mothers have less social support from family of origin in particular, and they are exposed to additional stress due to homophobic discrimination. This can be in labor and delivery, this can be in early parenthood. It's just that in general, they're treated differently. Trans, gestating, and non-gestating parents experience higher level of loneliness during pregnancy. This is especially high in trans men who are having pregnancies, because they sort of have 3 options for navigating that pregnancy. One is sort of impersonating a cisgender woman, which generally causes a lot of just gender dysphoria and loneliness. And then the other option is sort of pretending to be an overweight cis man, and sort of hiding, like continuing to be trans and not being open about the fact that they are trans, but hiding the pregnancy. The third option that has the highest rate of sort of social difficulty is being an openly transgender man who is pregnant, because that challenges a lot of gender norms in particular. Interestingly enough, bisexual women, which is the largest portion of the LGBTQ plus parent population, they have the highest risk of perinatal mood and anxiety disorders, especially if they're living in rural or suburban environments when their partner is a man, and if they're not connected to the LGBTQ community. An interesting part of this study was where these bisexual women were talking about how people assumed they were heterosexual just because they were having babies. In gay male partnerships where they had surrogates, they reported a lot less positive feelings at the end of a pregnancy compared to lesbian mothers who were carrying pregnancies. but more positive feelings about parenthood in the early postpartum weeks, especially when compared to their heterosexual peers. In Israel, there was a really interesting study saying that 12% of the surveyed gay male fathers using a surrogate had PMADs, which is about 50% higher than the 8.8% of fathers in the general population experiencing a perinatal mood and anxiety disorder. On that topic of like partners rather than birthing parents, they were often feeling like they were treated like they weren't a real parent because they weren't genetically connected to the baby in lots of areas of their life, whether it be family, friends, people at work, or healthcare providers. For lesbian non-gestational parents, so the common sort of joking term you'll hear sometimes is the other mother. Feelings around not being biologically connected to the baby may be related to their own desire of pregnancy or not being pregnant, as well as if there's a complicating factor of infertility when they are living with a pregnant partner. It can be self-doubt, jealousy, even concerns about what their relationship with the baby will be like if they're not the one who carried it. We know from looking at perinatal mental health in all people surveyed that social support is really correlated with positive mental health and wellness outcomes. A lot of the non-gestational parents reported in this one study that there was a lack of resources for them, especially mental health, because so much of it is about birthing people. And a lot of the services that were available didn't address intersecting identities such as like race, gender, sexuality, economic status, etc. And there's really just not a lot of research addressing the health implications of pregnancy in a partner as opposed to in that person. This is going to be a really quick overview of some of these terms coming up in this next section. Because some of them get conflated. Gender dysphoria is the most common thing that we talk about here in the trans community, where there's just a mismatch between gender, which is a social idea of what is expected from people based on sex, and then sex assigned at birth is, you know, this is your biology and this is the sexual organs you have. So when there's a mismatch between those organs and someone's personal sense of identity and how they relate to society as at large, that is just gender dysphoria and being transgender. Gender dysphoria is the extreme distress that happens from this mismatch because society at large has expectations about how people should be based on gender. And so this distress is related to not wanting to perform to meet those standards. Gender dysphoria is not a mental health disorder. It is classified in the DSM-5 to describe a cluster of experiences, but is not inherently pathological. It is easily improved with gender-affirming care, whether that be clothing or hormones or surgeries. Perinatal mood anxiety disorders are more common in these transgestational parents because these transmasculine people are having changes in their body that look more feminine. And so it goes against how they've been trying to portray themselves. We already talked about these sort of options that transmasc people have in terms of coping with pregnancy. What I see in general is that gender dysphoria can be conflated with body dysmorphia. I'll hear people say gender dysmorphia, but these are separate ideas. Body dysmorphia is relatively rare. It's usually about 1% or less of the population. It's an anxiety disorder characterized by preoccupation with a perceived body flaw that is not improved with making body changes. So think of somebody who has plastic surgery for their nose but no matter what they do to their nose, they're just not happy with it. And it's such an intrusive thought that it really decreases their quality of life.
Featherstone, we have a question here, I think related to your previous slide. It says, when trans men or gay men show signs of PMADs, is it often misattributed to their non-traditional situation? And if yes, does that undermine their access to the right supports for them?
I wonder if I can see the chat. I'm going to try to see the chat to read. I feel like there's two parts to that question. I feel like in general with the queer community, there is often a pathologizing of queer identity. So yes, a lot of people there is a misattribution of mental illness to simply the fact that people are queer. But I don't know that there's research to talk about access to the correct support. I will say that I would not be surprised if trans folks struggle to find reproductive health care that feels inclusive. It's kind of rare for healthcare clinics to advertise for trans folks or queer folks specifically at the intersection of perinatal mental health. I think as we have more and more openly non-binary, gender fluid, two-spirit, et cetera, like trans and gender non-conforming folks who are out and having babies, those resources will continue to increase, or hopefully we can just have the current perinatal mental health resources be openly more inclusive. But I think because it's still a minority and there's so much current negative publicity being given to the trans community in general, especially with legislation, I would expect that it would be hard for them to access the right supports. Absolutely. I'm going to really breeze over this slide about intersex folks. This is something that we don't talk a lot about outside of the urological community. Intersex is a socially constructed category that reflects very real biological variation in people. So we talk about sex in the binary of like men and women being in the idea of like female sexual organs versus male sexual organs. But intersex people have some degree of both in terms of hormones, genetics, reproductive organs. Like a lot of people who are intersex women who have, predominant, they have a uterus, they have ovaries, they menstruate, they can get pregnant. A lot of those intersex women, if you look at the bottom paragraph, a lot of those women can get pregnant when they have like a full uterus, but the issue is that they have much higher rates of stillbirth and miscarriages because that uterus is not as large as women who are not on the intersex spectrum. So that's just something to be aware of. I feel like we don't talk about that a lot, that there are, babies with ambiguous genitalia who have surgery, and then those people go on to have higher rates of transgender, non-binary, or gender expansive identities. So when we're looking at risk factors for perinatal mood and anxiety disorders in this population, I really like this Venn diagram of like how these folks end up in the middle, where there's elevated PMAD risk factors like decreased social support. There's increased trauma histories that are often related to family of origin. And then there's the minority stress of being discriminated against in society at large. So it's sort of the perfect storm. We talked briefly about the current hostile legislation, which is usually increasing anxiety in a lot of these folks. There's a lot of transphobia, trans violence in the news cycle, lack of protections for gay marriage, sort of the concern rising in the community about if same-sex marriage is going to continue to be available in a lot of places, and rising bigotry and hate crime. It can be a really difficult legal process to become the legal parent of a child that you did not gestate. There can be a lot of like misgendering on birth certificates because it never asks for birthing parent. It just assumes that it's the mother. Sometimes there's like social services involvement just for adoption of an infant that you've been involved with the conception for a long time. And then assessments for like assisted reproductive technology and the complicated process of the legal aspects of surrogacy. There's a really big financial burden, not just with the legal requirements, but also the assisted reproductive technology involvement for these families. And it's already a perinatal mood and anxiety disorder risk factor just to go through assisted reproductive technology. They're usually more involved in the NICU. They have higher rates of loss. There's more complicated and compounded grief, and a lot of people describe it as traumatic. There's not a lot of birth trauma specific research for the trans community, but there is a lot of documentations about trans parents and fear of childbirth, especially after hormonal treatment, which can change the vaginal canal. And we talked about like the sort of social factors that can contribute to mood and anxiety disorders. As far as infant feeding, I encourage you to be very open-minded and asking a lot of questions about planning. Don't assume that it's the birthing parent who is wanting to breastfeed or chest feed or body feed. There can always be, lesbian couples where the other partner will want to be more physically involved and choose to induce lactation. However, there will be some trans masc folks who have the option of chest feeding and may elect to do that. So holding those assumptions is really important. There's even documented cases of trans women inducing lactation and feeding their infants. And they're not super common, but the case studies that have been done have found that there's really positive mental health outcomes for these trans women. And these infants are growing and developing normally with the rest of the cohort of like infants who are being breastfed by cisgender women. So I think there's a lot more research to be done as far as like the nutritional content of that milk and if it's different from cisgender women or non-binary folks who are assigned female at birth. But this is a really interesting way that we can incorporate folks who are trans into the feeding and growth and development of their infants. These are some interesting quotes about trans motherhood and the sort of induced lactation. But, obviously people who were socialized as men don't know much about breastfeeding. And so there might be more education that trans women might need if they're choosing to induce lactation. For trans masculine or non-binary folks who are chest feeding, it's important to have a conversation about language that they're comfortable with, because using words like breast and sort of the hands-on quality of especially like lactation support can trigger a lot of feelings. So these are conversations that are important to have, as well as being aware that some gender affirming treatments might include resuming testosterone, as well as plans for what we call top surgery or a bilateral mastectomy for someone's body silhouette to be more masculine. We don't have a lot of data about safety of using testosterone in lactation. So that's not something that we generally recommend. So that's a part of the breastfeeding conversation to have with folks. These are some great resources. as far as queer family building and supporting parents, as well as reproductive technology for queer families. The book that I put on here that I really love the most is called The Natural Mother of the Child, a memoir of non-binary parenthood. It's by, Chris Malcolm Belk. I will say that this is not a LGBTQ 101 book. Chris really throws you into his lived experience, and it's like a series of little snapshots of his life, and how it was for him to carry one of his children, to gestate one of his children compared to when his wife gestated their other child. It's very thought-provoking. It's very interesting. You get a lot of insight into that experience as someone who identifies as non-binary and socially presents as very masculine, even though they were raised as the fifth daughter in an Irish Catholic family. And so it gives you a lot of insight into those family dynamics, both early in life and as he became a parent, and how his family of origin really struggled to conceptualize him being pregnant. So I also included some protocols for inducing lactation. These are not scientific resources so much as are socially available within the queer community. And then there's a breastfeeding, frequently asked questions for trans and non-binary parents. Caveat being they only use the term breastfeeding. They don't use any more inclusive language. And then the Academy of Breastfeeding Medicine has a clinical protocol for the queer community and lactation. There's also queer specific groups for perinatal mood and anxiety disorders, as well as social support. There are a couple trans perinatal resources, transfertility.co and transmasculinereproduction.sites.ucsc.edu. And there are a Facebook group for trans reproductive support, as well as a UK resource, parentingqueer.co.uk. And then we have these lovely pictures. My co-author of these slides and I used pictures that were mostly of people that we know. A couple of them are pulled from public news articles, but just to give you an idea of how these families can look, similar or different from families that you deal with every day. So you can't assume, any patient or family is of any particular sexual or gender identity. And that's why it's important to ask as a part of your intake. Shameless plug for the queer and trans parent support group through Postpartum Support International. One of them is hosted by a queer woman, my co-author, Laura Vladimirova, who's based out of New York. I'm not sure if the other organizer is still involved, who was a cisgender heterosexual therapist as well. And it goes up to 2 years of age. It's for gestational, non-gestational, and adoptive parents. And it's Wednesdays at 2:30 Eastern time. I'm going to stop sharing now. I'd love to hear if there are any additional questions or things that anyone is interested in. I see one here by
That
Lauren.
was the question in the chat you answered earlier. Thank you, when we were on the PMAD slide.
Oh, okay, great.
Yes. Thank you.
I saw
so
a comment.
much.
I want to address Janine's comment, where she talked about never hearing about toxic curiosity. Lots of folks are guilty of that. It's not ever usually on purpose. But there is a phenomenon, especially in the trans community, where healthcare providers or mental health folks have never interacted with a trans person before, and they will feel like it's their opportunity to ask all the questions. And it almost ends up like someone's paid healthcare time is used educating their provider, which is really not what people are coming and paying for when they seek care. So just being aware of not sort of like tokenizing or placing a burden of education on folks who are from marginalized communities especially because some of that information can be traumatic to rehash. And if they feel like it's not relevant to care, it can feel very invasive and uncomfortable, but because of the power dynamic of healthcare providers and patients, it might not be easy for them to decline to answer those questions. Sorry, I didn't mean to cut you off.
Oh, that's very helpful. Yes, to talk about that. Thank you for sharing your expertise. This was wonderfully rich learning experience. I know for myself and probably many in the room. We still have a few minutes. I know we have a hard stop at 12:45 today, but we'll stay on if you all have questions, comments, want to talk to Featherstone. I think I might see Michelle says very eye-opening in the Q&A. So we have a few more minutes. Janine also says the power dynamic is a good point. Plus, they might assume if it's asked, it's relevant.
Yeah. And there's a lot of evidence that trans and gender nonconforming folks who interact with healthcare environments have a really high percentage of like what I would categorize as traumatic interactions, where they were openly discriminated against, they're misgendered, nursing or other staff outside of the healthcare providers in particular can be really dismissive or otherwise have negative interactions. And this can really decrease healthcare seeking because they have these negative interactions. And it wasn't really salient to this particular presentation, but like trans folks in particular are, I want to say it's like 50% more likely to be dual tobacco users or dual nicotine users. So not only will they smoke cigarettes, but they will also vape. And so that is a significant health concern, especially from a cardiovascular standpoint, that like we want those people coming into healthcare environments. We want those people being talked to about smoking cessation. So it really is important for us to make safe environments for marginalized folks so that they get the care they need.
Absolutely. Any other questions or comments as we're wrapping up today?
Okay, well, thank you so much for having me, Lauren.
Yes, thank you so much for coming. And just a reminder, this recording will be on our YouTube, our VNPC YouTube channel in the next 48 hours. So thank you all for attending. Thank you, Featherstone. And with that, we'll wrap up for today. Thank you all.